Broadcast is live. Assalamu alaikum. كل سنة وانتم طيبين. This is a first for me. I'm doing an online hands-on demo. Introductions. أنا اسمي الدكتور أشرف سمير رفاعي، أستاذ مساعد بكلية طب أسنان جامعة الأزهر. والنهارده شرف ليا ان ابقى موجود مع شركه بيرفكت دنت، الوكيل بومدنت في مصر. They give me opportunity to give a live stream of say a hands-on in case of a root canal treatment. So as you can see on the screen, and right now I'm the one talking to you. In a few moments, I'm going to switch the screen to the tooth that I'm going to be treating. This is designed as a basic root canal treatment from start to stop. I'm just going to be showing you the techniques involved. This is a very useful lecture for undergraduates, for newly graduates, on how to deal with regular root canal treatment. And in it, I'm going to be doing an access cavity, obviously. I'm going to be negotiating the canals, and I'm going to be showing you a preparation and obturation of one of those canals. Now, you can see on the right here the x-rays. I took x-rays in the buccolingual dimension and in the mesiodistal dimension. So this is the tooth that we're going to be dealing with. Now, الفترة اللي جاية دي, I have somebody on standby with for questions and answers. I'm just going to be looking in on the questions and the answers, and I'm just taking a look right now. Give me a moment. Mahmoud, are you live? Mahmoud? Mm-hmm. Okay, so there we go. We are ready in business. Share. Dr. Mahmoud. Just share these technicalities. Okay. You can go on to the page and answer the questions if you get any questions. عنده أسئلة. Just open your phone. You don't need for me. Okay, from your phone. You can get the questions from your phone. All right, so we're going to start now, and I'm going to shift the screen to the microscope. Okay, here we go. Okay, so here we go. This is the view from the microscope, and you can see this is an upper, maybe, I think it's an upper 7. All right, it's the second maxillary molar, maxillary second molar, and I chose one today with a very large cavity from the side so that I can show you the access cavity happening real time. Because usually when we do these access cavities, we do it from the occlusal surface, and you see the forming over the tooth, and you can see the axis being drawn, but you don't really know what's happening inside the pulp chamber. So what I'm going to do is I'm going to show you the steps of access cavity preparation when you can see it from the side of the tooth. And this is a really big advantage so that you can imagine what's happening inside. Obviously, a lot of times when we're doing root canal treatments, the carious exposure is very obvious, and we just start our access cavities from the carious exposures. So there's been a lot of talk, and there's a lot of clinicians discussing the idea of conservative access cavity designs. And conventionally, we would really enlarge our access cavities with a divergent access cavity to allow for light and visibility from the occlusal surface. But with the advent of microscopes, the need for this type of access cavity has become less. Immediately when you have light and visibility, your access cavities become smaller by design. So instead of opening large access cavities with divergent cavities, we can open more convergent cavities and still get straight line access into the canals without compromising a lot of tooth structure. Okay? And if there's any problems up to now, please inform me. I can answer any of your questions. Okay, contra, please. Round. I did just stand there, please. All right, so when we do our access cavity, we usually start in the center of the tooth, and we aim towards the largest space. So usually when I'm doing a maxillary molar, I would aim towards the palatal canal so that when my bird drops in, it drops in this space, not perpendicular, so that it doesn't enter into the forcation area. Okay, so here we go. And can we start, please? Wait, Maya. Go. Stop. Pretty contra canal. Contra canal. Okay, sorry, just having technical problems. We just want to change my contra angle. There's something wrong with it. Any questions, Dr. Mahmoud?
No.
Not yet? How many people are viewing the channel?
64.
Okay, شباب اللي عايز يسأل سؤال go ahead, no problems. My assistants صايمين أعصابهم متوترة. يلا go. You can see I'm still penetrating into enamel, and there I'm. Stop. I have another round Britannia. So I misplaced my axis a little bit because I'm looking from this way. I should go more towards the center. I can adjust that, it's not a problem. Go. No, this is too big.
Here is a question, Doctor.
Yep.
Is it a restorable tooth, Doctor?
No, this one, Soel Gali, is this a restorable tooth? Obviously, this is not restorable. It's maybe 4 millimeters under the cervical margin. So it's not really restorable, but that's why it's extracted. That's why it's in my hand. It's not in the patient's mouth. So it's not a restorable tooth, but it is very useful for the purpose of my treatment today to show you a case with an access from the side so you can view what's happening during the access cavity preparation. Go. Okay, and then I'm moving towards the pulp chamber. There, stop. So you can see now I penetrated. And when I penetrated, what happens? I fell into the palatal space. Now you can imagine if I didn't feel that and I moved towards the forcation, there's always a high possibility of damaging the forcal floor, or in the end, actually, you can see there's the initial penetration into the pulp cavity. So here I have access now into the access into the pulp chamber. Now what I'm going to do is I'm going to enlarge my access cavity using an endo-zebra.
Here is another question saying, name of the probe you use.
The probe, this one, okay. This is an endo probe. It's very sharp. You can see here, it's used just to probe yourself into the canal. I don't know the name of this specific one, but it's just called an endoprobe. It's long and it's got a very thin tip. Okay. Endo-Z. Endo-Z, please. Okay, so I'm waiting for my assistants to wake up. And all right, so let's go in now. I go into the Endo-Z. Go ahead, start. All right, this is what I would normally do in my access cavity preparation. This would be a conservative access cavity preparation right there. Stop. This is what it would look like from the occlusal. It's a very, very small access cavity, and if you can see, it's all divergent. Now, normally, if you were doing a regular access cavity, you would converge the access cavity here and here. But for the purpose of this demo, go ahead, please. I'm just finishing off. Stop. Go ahead. All right, stop. Now, obviously, when you look here, you're not seeing all the orifices at the same time. Is it? I'm going to zoom in a little bit. And you can see here, this is much better within the access cavity. And you can see here clearly that you will not be able to see all the root canal space. You'll have to tilt your mirror to see the buccals and tilt to see the palatals. Now, this is the deal when you are doing conservative access cavity designs. You won't see everything in one view. Unlike when you use a more conventional design, I would probably open up my access cavity further to the palatal, further to the mesodistal, and further to the mesiobuccal here, so that I could see everything in one view. Now, the point of having a view is to be able to access the root canal parallel to the long axis of the root. Now, if you take, can I have a file? File, please. What's your minute, please? Yeah. Okay. So say I'm just going to start with my negotiating file of file 10. If I insert my file 10 and it goes in passively, you can see that it's parallel to the long axis of the root canal. There you go. So I don't need any more access for straight line access. Now, if I look at my palatal, I will probably see the same thing. You've got straight line access. Even actually here, I could have had even less access. I could have reduced my access even less because I have perfectly straight line access here because my canal is divergent and the instrument is entering in very, very freely in a passive motion. Then we have the mesiobuccal, and if we look at it from this view, you can see as well it is quite straight. So I've got straight line access. So the purpose of my access cavity here is to locate all my canals. Yes, I have located all my canals. And I have straight line access to all my canals and my palatal canal. So there's no need for me to open any more coronally. But if you see, you can still see that there's still pulp horns here and here. This can be cleaned out using ultrasonics and therefore remaining more conservative during your treatment. Okay, can I have an ultrasonic?
Here comes a question.
Okay.
Which one do you prefer, using Endo-Z or ultrasonic tips?
Right now, I'm going to open an access cavity using ultrasonics as well. I don't open a complete access cavity with ultrasonics. So the question was, what do you prefer? Do you prefer using ultrasonics or the Endo-Z?
Yeah.
I use the Endo-Z for a part of the treatment. And then right now, I'm going to use the ultrasonics to finish and refine my access cavity without damaging and removing a lot of tooth structure.
Some people asking if you can raise the volume.
Raise the volume. I don't know about that. I suppose this is the best we can do with the volume raising because I'm right next to the screen, Asif. Okay. Max, go. So this is an ultrasonic instrument. We cannot use an ultrasonic instrument to completely open the access, but we use it to refine. Go ahead. Maya, please.
Maya.
You can see the aperture of my access cavity has not been enlarged. I'm retaining a very large amount of dentine and enamel, and I'm removing vital tooth, vital pulp, or the areas which would have vital pulp in a tooth. Also, I'm troughing around the access cavity so that I can see. As you can see, this is very conservative. There's no need to get really aggressive. Chip syringe, please. Now things have become Prof, please. So here you can see I went in a little bit towards the mesial, so you can see all the mistakes I made. Something like this I would prefer not to have, so I would probably make my access cavity maybe 0.5 millimeter smaller in this direction, and you can see here there's still a pulp tissue remnants, but this can all be cleaned out using ultrasonics, and there's no need to use it. Now, conventionally, you would have probably opened up your access cavity all the way around here so that you could have immense access. Now, that is true when you're not using magnification, but when you're using magnification, ultrasonic space, when you're using magnification, it requires some, you can be more conservative. Go ahead. Maya? Okay, there we go. Now, okay, so I finished my access cavity. I finished refining my access cavity. I've located my orifices. Now, it's very important. You can see from the X-rays. Okay, so that's the first step of treatment, where you can see from the X-rays, this is a 3-canaled upper molar. There is no second molar. I took a mesiodistal view and a buccolingual view, and it's very obvious that it's only a 3-canaled molar. So I'm just going to pick one of the canals as an example for a treatment. I'm not going to be preparing all 3 of them today, but I am going to be preparing one of them from start to finish. Okay? So, back to the tooth.
Doctor, there is a question here saying, are you using a diamond-coated ultrasonic tip?
That's a good question. The tip that you saw was not diamond coated. The tip that you saw, this was it has a micro mill tip. It has flutes. Can I have the microscope? Can I have the ultrasonic? Sorry. Okay. You can see this ultrasonic. I'm going to zoom in a little more. You can see it has flutes. These flutes are sharp and they vibrate and they cut. It's called a micro milled tip, and it's not diamond coated. It's not smooth.
Another question saying, when to search for an extra canal?
When to search? All the time. بالبلدي كده, you have to always imagine that there is a missed canal. So say this is your mesiobuccal, all right? That's the mesiobuccal canal over there. You would probably be looking in the space between the palatal and the mesiobuccal for an extra mesiobuccal tooth. But we're always looking for extra canals. ممكن الألتراسونيك رقم 3. Okay, always looking for extra canals. So I would say here, if this was your mesiobuccal, you would probably get a mesiobuccal 2 somewhere here, right there. But they look like these are going into the same canal. I mean, this is just, but that's where it would be. So I'm just going to zoom in and show you what it would be like if there was there. You can see it. So that would be your mesiobuccal 1 and your mesiobuccal 2. So you always look for extra canals. Definitely, there would be a time for discussion on how to find missed canals and the anatomy involved. That's a whole big lecture. It's not a small discussion for one day. Ultrasonic. So just to show you what I would do, if I was worried that there would be an extra canal, I would probably begin to use an ultrasonic instrument in the area right here. Go ahead. Ultrasonic. I would do this. I would trough like this. This is called the troughing procedure, to make sure that there is no extra canal, or if I'm thinking of looking for, this is probably where it would be. Irrigation, please. These are in it. So here, for instance, can I have a Pro, please? This is your mesiobuccal canal very clearly, and this is just a trough here. There is no extra canal. I don't think so. And then this is when I would start using a lot of irrigation. This is actually sodium hypochlorite, and I would irrigate into my access cavity. I'd leave it there for a while. Okay, and if you look very closely, you can see bubbling. Can you see the bubbling? Bubbles واضحة على الشاشة. Show me كده. Yeah, let me take a look. It's not clear. Well, you can see there's white residue. That's the residue of the bubbling. Those are bubbles, but it's not very clear. The resolution is not very clear on the screen. Okay, so in this case, again, chip syringe, please. Fine option. All right, so here is where you may find an MB2 right there. So you would probably look right there, and then right here, that's your MB1. I would trough behind this a little more, ultrasonic please, just to see if it's actually an MB2. Go. Maya, please. Maya, please. Sometimes I use my ultrasonic dry. Go. And I use it wet. I alternate between dry and wet. Stop. Okay, file 8 please. So this is just like a trough. There is no canal here like I told you, but this canal is just connecting to the mesiobuccal one. Okay, so this is an example of a troughing procedure where I didn't find an extra canal. Ultrasonic, please. Go ahead. Go. Maya. Stop. So there, that's an example of a troughing procedure. Still trying to find the MP2. Could you find the KV, please? So pre-bend. Yeah, like I said, there's no MP2. Now, but that's what it was like. If there was an MP2, this is where you would find it. This is where you would find it in the area between the palatal and the MB1, and you would start looking. But to be able to visualize, you probably need some sort of magnification. All right. Now I'm going to use this same canal as an example for preparation. Okay. So I'm going to estimate my working length. In this case, I'm just going to let it peek out. You can see it coming out at the apex. And I'm going to pull back about, tweezers please. I'm going to use my mediobuccal cusp as a reference point. And I'm going to pull back 1 millimeter from this, or half a millimeter from this. East, please. So my working length is, I would say, 18 and a half. Okay? So my working length is 18 and a half. Any questions, Mahmoud? Okay. Now, the next step in endodontic treatment would be what we call negotiation. Now, negotiation is for you to make your first instrument reach the full working length. And in this case, I would use glide.
Glide.
There you go. And we would, as you can see, some glide on the file. I would insert it in there, and I would start working my file into the canal until it comes out. In this case, but in the patient's mouth, you don't do it until it comes out. But I want you to see the motion involved. You do very light motion. You go in and you go out. And if there is resistance, you go in and you go out until you reach the working length passively. And then I irrigate. Irrigate. Okay, I'm irrigating. No forceful irrigation. It's called passive irrigation. And then I'll use a 15. Again, I will adjust its length to 18 and a half. And I will insert. Watch my motion. Very mild motion. You can see here. I'm not trying to force the instrument. If I feel any resistance, I come out. I go back in again. And I try to take 1/4 of a millimeter to 1/2 a millimeter each time I go in, each pass of my instrument, so that I don't try and take too much in one time. So now I've got a tightly fit instrument in my mediobuccal canal. I'm going to go in, work the instrument a few times. There you go. And now the instrument is relatively loose in the canal, goes in with some ease and come out, not completely loose. But now I know that my starting point of my canal here is a 15 to the working length. After I do my 15, I'm going to go in with a recapitulation with a size 10 and make sure that my canals are patent, and it's going to peek out just a bit. And I'm going to irrigate again.
Everyone is asking if you could raise your voice.
Oh, okay, I'll raise my voice a little bit. Okay. I don't know why there's a problem in the mic, but is this better now? And how does that شوي? أزعق فيكم شوي. Okay, so I'm irrigating now. I'm irrigating, and is the mic not high enough? The mic should be high enough. Okay, so. All right. Okay, so the next step will be to do the preparation. I have negotiated my canal to a size 15. This is the start point for any instrumentation process. At this point, I'm going to start enlarging the coronal portion with a flaring file. And I'm going to be using a two-file system today to enlarge my canal to a 6% taper. So first start will be doing a coronal flare. So that's the next step. Okay, go ahead. Coronal, right? Hello, motor, flaring instrument, flaring file. A little more irrigation. Can I have EDTA? Before I start my prep, I just stick in some EDTA, clear up debris, EDTA. EDTA, No, مش okay. Okay, sorry, there's a little technical problem with my microscope. So until it's just, it's going to be fixed in a few minutes. Until it's fixed, we can have some questions regarding the what we've discussed or what you've seen in the last half an hour. So, okay, I'm listening. Does anybody have any questions? No questions? Okay, so the next part of the session will involve me preparing the canals. The canals will be prepared using a dual instrument system to a size 2506. The first step that I did before we had the technical issues was coronal pre-flaring, which is an enlargement of the first 3 or 4 millimeters of the canal space using a large tapered instrument. Usually these tapers are from 8 to 12%. And these 8 to 12% do the job of what we used to do using a Gates Glidden drill. The Gates Glidden drill would enlarge the coronal part to a very good size to allow for irrigation and easy access to the canal and to reduce the overall curvature of our canals. So the next step after coronal flaring would be doing in negotiation to the apex again, and then I would go in with my enlarging instruments. So we're just waiting for this little technical problem to be fixed, and I will be back again.
Here are some questions.
Very good.
The first one is asking, can you discuss the number of ultrasonic tips you use for different purposes?
The ultrasonic tips are there are many different types. You have ones which are diamond coated, ones which are non-coated. In the case today, I used what we called micro-milled ultrasonic tips. They have very small flutes on them. And today I used two types of ultrasonic tips. I used a thick one, which I refined the access cavity with, and then I used the thin one, which I troughed with. You can't trough with a thick ultrasonic instrument; you will perforate. The one I was using is called the StartX 3 from Dent, and that's the one I was using to trough with today. I use it very often to trough.
How can you deal with a calcified canal? Negotiating calcified canal.
If you notice the way I was dealing with the canal a few moments ago, it's the same way you deal with them. Sorry, I'm just trying to fix my technical issue here. There we go. One moment. Right. Yeah. Okay. Now, in a moment, I'll be back on the mic. I'm just fixing the technical issues. Say the question again, Mahmoud.
Negotiating calcified canals. How can you deal with calcified
canals? The way you saw me insert my instrument into the canals, the same way I deal with narrow canals. Narrow canals just require narrower instruments. There's no way to force yourself into a canal with a thick instrument. You definitely need narrow instruments to get into narrow canals. So the only way for you to negotiate narrow canals is to use small instruments, pre-curve your instrument, and begin to ease the instrument into the canal very, very lightly. Don't take too much. Don't try and force and rotate the instrument a 360-degree rotation, a very mild 15-degree rotation, clockwise, counterclockwise. Come out, irrigate, and keep on doing this until you reach the full working length. Is every single canal which is non-negotiable negotiable? No, not every canal is negotiable, and sometimes it's not possible to negotiate every single canal. But I would say maybe 8 out of every 10 canals which people consider non-negotiable, I would negotiate.
Can you give advice concerning refining the axis?
I don't know if you saw the video when I first started. The video was of an access cavity which I opened up using a round burr and then an endo Z burr. The ultrasonics are used to clean the areas which are overhanging, without the necessity to remove the overlying tooth structure of enamel and dentine and losing all that tooth structure. So you can go back, look at the video, and you see how I refined the access cavity with the ultrasonics. Or if you have a more specific question, I can answer. Any other questions? That's it? Okay, so I'm going to sign off from here and get back to my scope. Hopefully, we won't have this technical issue again. So, assalamu alaikum, just give me a few minutes and I'll be back again. Okay, I'm back and I'm going to start. I don't know, there's some reason why the microphone is not loud enough. So I'm going to start screaming so that everybody can hear me. Okay, so the next part, you can look, you can see, there's my access cavity. It has become, and there is my mesobuccal canal. There you go. You can see it very clearly. And now I'm going to start enlarging the apical area. I've already done my recapitulation, my patency, to make sure that there's no debris and my apex is patent. And now I'm going to be using my second instrument. I remind you that my working length is 18.5. Okay, and the instrument I'm going to be using in the canal right now is a 25.4% taper instrument. Can I have my M block, please? M block. Okay. All right, so here, and then we would rinse in the canals again. I have irrigation. I would start my instrument. Again, this is the Wisming instrument. Just adjusting the settings. Okay. Again, you will watch my motion. You can see the hand motion I'm doing is very light motion into the canal. And you can see it very clearly until I reach the working length. Once I reach the working length, I come out. I don't linger. So that's my first instrument. After that, I would irrigate. You can see now that the needle penetration into the canal is quite deep. I've reached about, say, the apical 2/3 there. You can see it. So that's how far my needle has penetrated from my first instrument. So I can irrigate very effectively to that length. Is everybody hearing me now? Can everybody hear me? There you go. Now I'm irrigated, and then again, I will do patency with the size 10 just to make sure that the instrument is patent to the apex, and then I'll go in with my second instrument. Okay, I'm going to adjust my length to 18.5 because that's my working length. There you go, 18.5. There you go, 18.5, very good. Again, watch the motion of my hand, very light incremental motion. If I find any resistance, I don't continue. I get out, and here I reach my working length, and I won't linger. Irrigation, please. Okay, so now I'm irrigating into the canal. I have nearly full penetration of the instrument to about 1 millimeter from the working length. And yeah, there you go. You can see it here. There. That's how far I get in. I'm all the way to the working length. I will irrigate, and this is when I would do my irrigation protocol. I would probably do EDTA and sodium hypochlorite alternations, and I would agitate. My irrigant solution with ultrasonics. That's what I would do at this phase. And you can see the canal all the way to the apex. At this point, I would consider that I've already done my final patency, Pipper points 25, just to make sure that there you go, my apex is patent. And now I would go through, like I said, I would go through the sequence of doing my irrigation protocol. You can see there that's sodium hypochlorite bubbling in the canal. That's sodium hypochlorite bubbling in the canal. And there you go. And I would dry with paper points. And at this point, then I would start doing drying. I would take an X-ray with a confirmation of my master cone. Isaac, got a pressure, please, 25. Yep. So there, the canal is enlarged, very clearly enlarged. There is your canal, very clear. Got a pressure, please. Tweezer. Yes, okay, so I'm going to go back out to a less zoomed situation. I'm going to I would put in my gutter pressure at this point, and I would take an X-ray, a confirmatory X-ray to make sure that it is to the working length. And yeah, okay, so we would take a master cone X-ray right now. Okay, so I'm going to let them take an X-ray. Take an X-ray. And I'll just sit there and I will flip and I will talk to you here. Okay, so any more questions up till now? Questions? I know I'm screaming because there's something wrong with my microphone. So if you have questions, I can do it now by the time they just take an X-ray, and we will be back. Yeah. Yeah, one moment. I'm just going to clear the room for the X-ray and I'll be back. Okay, so if you look at the screen, you can see the gutta percha is about 1 millimeter from the working length. That's exactly what I did. I put it about 1 millimeter from the working length. Probably with my obturation and the vertical compaction is probably going to go all the way to the end. So now we're going to go through the process of obturation using warm vertical compaction. Okay, so back to the case. All right.
There is a question saying, can you discuss the irrigation protocol you use to your practice? Can you discuss
Yes.
the irrigation protocol?
Okay. I discuss irrigation protocol. Okay, I'm going to discuss my irrigation protocol at the end of the procedure. Just let me go through the obturation procedure, and then I will discuss my obturation protocols. Okay, my irrigation protocols. Can I have Lincillo spiral, please? Mix the sealer. So now my assistants are going to mix the sealer. I'm going to insert the sealer using a Lincillo spiral into the canal. Go. Stop. Okay, so my assistants have mixed my sealer. So I'm just going to insert some sealer here into the canal. Activate, please. And then we rotate it into the canal very nicely. Thank you. Canal cone. And then I will insert my cone to the working length as previously discussed. Now, this is the first step of the warm vertical compaction. Okay, so here you go. I'm going to just cut off the gutta percha at the orifice. Plugger, please. And just compact it lightly at the orifice here, very lightly, just to create a snub of gutta percha. And then I will adjust my length to be about 5 millimeters from my working length. So that would be how much? 14 ونص, 14 مثلا. Okay. And I would touch the tip and I would activate and push forward. And there we go. I hold this for about 5 to 10 seconds. And then I will do a little activation. So I get some of it coming out and some of it inside. Can I have a plug of Refaie? You can see that there's still material. It's still hot at the apex. And I will do condensation, compaction of the gutta percha to the apex. And apply a little pressure until it cools. And then we will have the last phase, which is the okay. And then I would do my backfill using this, you can see there, and I will inject, fill up the canal backwards. Plug it, please. الأزرق. So I am applying apical pressure, compacting the gutta percha in to the orifice. برضه نفس المشكلة في الساوند يا محمد؟
لا, it's clear right now.
All right, so now I have my obturation. It's done, and I'm going to give them the tooth so they can x-ray it, and I will be able to answer any questions related to the procedure.
Somebody asking, if you have to guarantee complete shaving of canal with 2 files.
A question, a very interesting question. Actually, I'm going to move to my other phone. So what I'm going to do right now is I'm going to go back to my other phone, and I'm going to answer the questions from my other phone. Okay, I was asked a question. How can you be sure that you have cleaned all your canals using 2 instruments? The idea of 2 or 3 instruments is not the issue. Okay, the idea is what is enough. What is enough with regards to what was my initial size at the beginning of treatment, and what is the size at the end of treatment. So if my initial size is a 15 and I get to a 2506, the number of instruments is irrelevant. What is relevant is how much of the canal has been enlarged. What has been the percentage increase? Have you increased 20%? Have you increased 30%, 100% of the original size? How much is enough? Did you take a postoperative?
Yeah. From 2
Okay, so I'm just going to take a look at my postoperative X-ray. Yeah. There you can see the postoperative X-ray. Right, it's a little short because when I estimated my length, I already estimated it about 1 millimeter short of the working length. So depending on where I put my working length is that will affect my post-operative directly. Okay, and the question is, yes, 2 files is enough. Are 3 files enough? Are 4 files enough? What is enough? That is the question you need to ask yourself. What is enough? Okay, so yes, in my opinion, a lot of canals can be enlarged with 2 files, and some canals cannot. For instance, if you have a canal which has an original size of a size 40, okay, how can you enlarge the canal with just 2 files? And if you look today, I didn't just enlarge the canal with 2 files. I enlarged the canal from a 10 to a 15. Then I did a pre-flaring using a pre-flaring instrument. And then I used 2 instruments to do my body shaping. So in reality, I didn't just use 2 files. I used a size 10, a size 15. That means I enlarged my canal from smaller to a 10, then to a 15, and then from 15 to 25, 4% taper, and then to a size 25, 6% taper. Okay. Any other questions? Any other questions? That's it? Where's the other view? There.
Yeah, this one.
Yeah, you can see here.
Better view.
Yeah. The canal has a lateral extension. Okay. Any other questions? That's it?
Irrigation protocol.
Irrigation protocol. Okay, when I'm irrigating, after I have done my pre-flaring, and I've enlarged my canal to a 25, 6% minimal, 34%, or any size above that, at this point, before I do my obturation, I start going through a sequence of 1 minute of sodium hypochlorite irrigation with activation, and then 1 minute of EDTA, sodium hypochlorite, EDTA irrigation with activation. And I do this maybe for about 10 to 12 minutes for each canal. And then after that, my final rinse will be EDTA, and then I would dry, and maybe if I wanted to use distilled water, I would dry and then I would obturate. That would be my protocol. Now, if I wanted to use CHX or chlorhexidine, I would probably wait to the end of those 10 minutes, and the last 2 needles of irrigation I would probably do with CHX. And obviously, if you wanted to use chlorhexidine, you need to split between in between the chlorhexidine and EDTA or sodium hypochlorite. You would need to use distilled water or saline so that they don't mix, because as everybody knows, mixing both sodium hypochlorite and chlorhexidine will create parachloroaniline, which is a very toxic material, and it's called the brown precipitate. Okay. Any other questions? Done? Okay. Thank you very much for everybody's attention. I'm sorry for the technical difficulties that occurred during the treatment. This was the first time for us. Technically, it was a difficult endeavor to try and have an X-ray and me talking and the microscope all live at the same time. I would like to thank Muhammad Salah, the General Manager of Perfect Dent, for making this happen. And inshallah, everything will be good. وكل سنة وانتم طيبين. والسنة الجاية إن شاء الله نشوفكم في أحسن حال. Stay safe and stay at home, and maintain personal hygiene and social distancing measures, and hopefully we'll get out of this as quickly as possible. Assalamu alaikum wa rahmatullahi.